About 25 years. For those of you who don't know me, I'll just mention a little bit about how I got involved. I ended up at the National Cancer Institute in 1986 after graduating from Tulane and in medical school and then doing my residency here at Tulane. And so what I ended up doing was wanting to go into oncology, and I went to the National Cancer Institute in Bethesda, Maryland, which I thought was the right place for me to go. It was a tremendous experience, and I ended up completing my fellowship in 1989, 3-year fellowship, general oncology. And then in 1990, I received a call that was a little bit surprising. It was an opportunity to join the prostate cancer group there. My response was, well, I don't know anything about prostate cancer. I'd actually, at that point, never treated a patient. And I said, oh, don't worry, you'll learn. And the nice part about it was I got offered a faculty position at the NIH, which is sort of a nice thing. It's not easy to get. And they gave me a laboratory, and they gave me some research nurse access and protocols. And so in about 1990, I started out to teach myself about prostate cancer, and it was kind of interesting. I had an endocrine background a bit, and that combination of endocrine background and oncology background really fit extremely well in prostate cancer, because a lot of what we do is endocrine treatment, and then there's oncology. So anyway, I've been doing it ever since. I moved to New Orleans in 1998 as the director of the LSU Cancer Center and the chief of the hematology oncology program at LSU. Stayed there till Katrina, and Katrina was a bit of a mess. If you weren't here, thank goodness, you probably just simply missed a bit of a mess. I left for 2 years. I had an opportunity to go up to Boston and be with the Harvard Cancer Center up there called the Dana-Farber Cancer Center. Did that for 2 years, and then it turned out my wife, son, and my daughter were in New Orleans, and it sort of made sense I'd be in New Orleans too. So I came back and started at Tulane. But anyway, that's enough about me. We have lots of blue themes going on. We have blue slides, we have blue shirts, we have blue dues coming up. I won't sell you on the blue do, but over there, not this Saturday, but next Saturday, we're going to have something we call the Blue Dues Celebration, Run, Walk, Party, whatever that means. And really what the idea is to sort of celebrate survivorship and to celebrate in a positive way issues that relate to prostate cancer. And it will be a run and a walk, but you can also just sit and enjoy yourself. That'll be fun too. Got a lot of generous people who've donated. We've raised, I don't know what the exact amount is, but I think we're up to be about $115,000 in support of prostate cancer research. And in addition, we'll have an auction and a band and just all sorts of stuff. So anyway, if you're interested in that, there's some flyers over there, and you can come out and join. Be on the Tulane campus. Great, thank you very much. Yeah, that'll work. So like I said, I have a hard time hitting that screen very well, so I'll probably point on this one. So this was actually a little bit of a difficult lecture for me to prepare, because when you talk about prostate cancer, there's so many facets to it. And anybody who's a patient here, and I know that a lot of patients will focus on their particular dilemma and their particular problem. Yet every patient is unique. Every patient, in fact, doesn't fit easily into the algorithms that we draw because of so many variations. So I thought, the best thing to do is kind of give a broad overview and then try to handle lots of questions. About 7:30, I'm going to probably try to run. And the reason for that is that tonight, the Tulane football team is going to have a blue symbol on their helmet, and they're doing prostate cancer awareness at a Tulane opening football game. And there are lots of people who can take credit for that, but I'm not among them. And Bob, where's the person? We have Idea Man, and then we have people who get things done, like Melanie and Keedron. And anyway, I think Melanie, you got on the television and was doing some interviews and stuff. But anyway, first time we've had a college football team sort of celebrate things related to prostate cancer. And I love pink and I love October, and I know October pink is breast cancer month, but did you know that September is prostate cancer month? And we're going to try to get a little blue going on as well. So tonight at the football, opening football game for Tulane, we'll have that. All right, update on prostate cancer. All right, so let's see. Just a little bit about the disease. It's amazingly common. It's the most common non-skin malignancy in U.S. men. Estimates are, and this will vary from year to year, it's approximate, of course, because nobody knows exactly how many people are diagnosed. About 240,000 men will be diagnosed. Breast cancer, you're running in the 230,000 range. So it's essentially analogous to breast cancer, but even a little more common. So among U.S. men, it's by far the most common malignancy. And in terms of death, which we don't like to talk about because our job is to prevent that, it's the number 2 cause of cancer death in men. But one of the things that I like to remind people, if you don't smoke, it's the number 1 cause of cancer in American men. And more and more people today are not smoking. About 80% of men are not smoking. So prostate cancer, for those 80% of men, is actually the number 1 cancer threat for them, if you will. So that's pretty important. But then when we look at these numbers, it's important to keep another framework in mind, and that is that what I call the incidence mortality ratio, how many people get it, how many people die. There's a lot of differences. And again, you can calculate different numbers according to incidence mortality, but if you use these numbers, it's about 8.6 to 1 or thereabouts. In other words, it's going to be 8.6 people diagnosed, only 1 dies. So the vast majority of men with prostate cancer are not going to die from it. And that's, the really good news that I want to make sure that people are aware of. Breast, 5.7 to 1, colorectal, 2.8, lung, 1.4, pancreas, which is kind of a bad one, is almost 1.1 to 1. So, it's not a death sentence at all. In fact, it's one of the things I'll be telling you about is for some men, simple surveillance and observation is all we'd recommend. We don't have to even treat everybody. This is what I call prostate cancer clinical stage, and I'm going to come back to this slide repeatedly because it sets a framework for how we intellectually approach the disease. We have people that have never had hormones, so we call that hormone-sensitive disease, and then we have people who are recurrent after initial hormonal therapy, and this goes by a number of different names, but I'll just call it recurrent after initial hormonal therapy because that makes sense. And you can be diagnosed with localized disease, or you can be diagnosed with metastatic disease. I'll come back to each one of these. And the first thing we have to kind of figure out is to what extent is your cancer? Is it localized or has it spread? And there's some people we don't even do scans on. For instance, on a Gleason 6, PSA less than 10, T1C, T2A, I'll come back to that. We don't even do scans because we know if we did scans, we'd have more false positive than results. On the other hand, these are people often with higher Gleason scores, often with higher PSAs. And in this case, the scans are critical in order to help us determine the extent of disease, location of disease. And then we have this one is these are people who may have been treated for localized disease, but the PSA is going up anyway. And you say, oh goodness, what do we do now? And this is often a bit of a conundrum. I'll address this a bit, and it's still not an easy nut to crack. And then some of these men will get ADT, and I use that intermittently. That's androgen deprivation therapy, that's hormonal therapy. And then we call it castrate testosterone because the testosterone is way low. We don't really have a standard of care here, so we do a bunch of things we're not really sure whether or not to make a difference. Unfortunately, if you end up with radiographic metastases and you're castrate, meaning the testosterone is less than 50, then we have a whole series of options out here. But ideally for these people, we want to keep them from getting here. For these people, we have to deal with all the options. So that's kind of the framework for how we approach this. And when we talk about localized disease, which is where hopefully we start for most men, it's about risk stratification and life expectancy. So the first thing we want to do is determine how the cancer is going to behave if we just leave it alone. And we can do that by using Gleason score and PSA and clinical stage. I'm going to go through this in a bit and this in a bit. Then there are a couple of other things. The extent of cancer on the biopsy. So when you get those biopsies, and often 8 to 12 is kind of typical right now. I'm just looking at a fellow up here in a moment, showed me his pathology report. I say, oh, okay, that's a little more involvement than I like there. Oh, that's 50% involvement there. So I'm looking at the extent of cancer. I'm looking at the number of cores taken, the number of cores that are positive, the extent of each core that is involved with cancer. And that gives me an idea about the cancerous volume, at least on the cores. And one thing that sort of overrides a lot of the other issues, and this happened to me yesterday, somebody has a family history of fatal prostate cancer. I almost make the underlying assumption that you might have it bad too. It doesn't matter what the parameters are showing me. So I had a guy yesterday in my office. He's 62. He's a nice guy. He's got a Gleason 6 disease, which I ordinarily just leave alone. Unfortunately, his brother died of metastatic prostate cancer. And you can imagine the fear and loathing that would occur under such circumstances. And, you know, I get very nervous, and I'll tell somebody if I'm nervous, you probably ought to be nervous too. And, you know, even though all of his parameters were looking good, his family history was so dreadful that I just didn't want to repeat his brother's experience. So that's a whole different thing. Age is important. You know, 42-year-old guys and guys that are 102 are not one and the same. And what we might go after aggressively in a 42-year-old, we might neglect in a guy who's 99, right? And comorbidities, coexisting medical conditions, somebody who's fit as a fiddle. I did, unfortunately, this past week see a guy, fitness workout guy, 45-year-old, Alabama, nice guy with a PSA of 300. I said, oh, you know, okay. But I said, look, this isn't all bad because you're young and you're fit. I can punish you and you can take it. I'm going to go in an incredibly aggressive way after your cancer. But if the same guy walked in and he was 89 years old, I couldn't punish him to the same extent. And these age and comorbidities and medical conditions and fitness all play into our decision making. So when I'm seeing a patient in clinic, this is what's going through my mind. Gleason, PSA, clinical stage, extent of cancer, number of cores positive, extent of the cores positive, family histories, age, coexisting medical conditions. That's the way I think about it. So many people, you know, quote, catch me on the street and say, my PSA is 8.3, what should I do? And, you know, what I really should say, sometimes I try to be a little more helpful, what I should say is, you need a doctor who understands more about your cancer than the PSA. Okay. So we're going to start talking about what is the most important parameter because it's not often understood. It's Gleason score. Dr. Gleason was a pathologist up in University of Minnesota. He worked at the VA up there. He was a researcher. And I'll be damned, this thing came out again. This is 3 = 4 = 7. You must think my math is really bad. It is. But I corrected that on my slides, and I don't know why it didn't come out corrected. 3 + 4 = 7, what it should be. And I'll explain that in a second. So Dr. Gleason, looking under the microscope, was able to discern that not all prostate cancer looked the same. Some of these cancers have these small uniform glands. So the prostate's ordinarily got a whole bunch of glands in it. That's what it does. It makes fluids. And sometimes there was a little more space between the glands, and sometimes there was kind of an infiltration. And then sometimes you had these sort of masses, and you kind of began to lose your glands. And sometimes, gosh, you just only had an occasional gland. So he came up with a system. He says, we're going to call this a 1, and that a 2, and that a 3, and that a 4, and that a 5. And he published this grading system, but he immediately recognized, and this was an interesting observation, that even in the same man, as he moved his microscope from place to place in the cancer, that the cancer would look different, even in the same sample. He'd get a particular field on his microscope, and it would look one way and make it look like a Gleason 4 or Gleason 3, and then he'd move over into the next field, and the cancer would look different. So he realized what he had to do is to capture what we now call the heterogeneity of the disease. And they do that by giving the Gleason score 2 and sometimes 3 different numbers. The first number that is used is the most predominant cancer. So you scan all around, and the pathologist looked under the microscope and said, okay, 3, 3, 3, 3, 4, 4, 4, 3, 3, 4. Okay, so that's a 3 predominant. So what he's going to do is he's going to say, that's a 3, but I got a lot of 4 in there too. So that's going to be a 3 plus 4 is equal to 7. That's how we get the 2 numbers in the total. So that's the way it started and the way it remains. But we've had some changes, and that's where people get confused. Now, this slide is a bit of a shocker. Because when I first saw it, I said, oh my goodness gracious, that Gleason score really is important. This is from Peter Albertson. These are from untreated men in the pre-PSA era. There are a bunch of people who said, I don't want to be treated for my prostate cancer. Dr. Albertson collected 900 of these people and followed them, even though they didn't want to be treated, and decided to find out what the natural history was. So we're asking the question now, what happens if you don't get treated? And I'm going to make a distinction between the pre and post PSA era. Well, first of all, if you got a Gleason 2 to 4, nobody ever died. Let me explain this. This is cause-specific survival. 100% means you're alive. 0% means that everybody's dead. This is a group of people in each one of these. Each one of these little falls represents a person or a couple of people going on down. Now you can see if you have 8 to 10 on your Gleason score, this is 15 years, 5, 10, 15 years after the beginning. If you got diagnosed with a Gleason 8 to 10 and you're alive at 15 years, well, you're just lucky. I mean, that doesn't happen very often. On the other hand, for the 2 to 4, virtually everybody is alive, not dead. And you can see 5 and 6 and 7 and 8 to 10 are very, very different. So the different populations involved. And this is sort of the original risk stratification and talks about Gleason score and how important it is. It is absolutely critically important. But you got to remember that this is untreated men in the pre-PSA era. Now, Dr. Albertson, and he's chairman of urology up at the University of Connecticut, great guy, trained at Johns Hopkins. Excuse me, really terrific guy. He realized that there's always what we call competing mortality risk. So, the bad news is, and this is going to be a shocker for everybody in the room, everybody's going to die, okay? We're all going to die. So the question is, what's going to get you? And he just had a very simple way of analyzing the data. He said, and if black means that prostate got you, and gray means that something else got you. And you can see in these low Gleason score patients, this is by age, 55 to 59, 60 to 64, 65 to 69, 70 to 74. If you're 70 to 74 and you get diagnosed with a Gleason 2 to 4, the black line there, and this is over 5, 10, 15 years, this came out of these studies, and these are untreated men. I should have put that up there. These are untreated men. You can see that the vast majority of men are going to die from something else if they have a low Gleason score and they get older. Now, you can look at a relatively young man, 55 to 59, and the black is pretty much all you see. There's a little sliver of gray down here. If you've got a Gleason 8 to 10 and you're 55 to 59, prostate cancer is going to get you. One of the reasons when somebody walks into my office and they have a bad disease and they start talking about, oh, well, do I really need to be treated? I hear prostate cancer is just a disease that old guys get and nobody ever dies from it. And, he's 55 years old with Gleason 8 sitting in front of me. And I said, you may have heard that, but it ain't true for you. Okay. Mm-hmm. So look how important the Gleason score is, even regardless of the age that you're diagnosed. Here you still have about 60% mortality from prostate cancer for somebody aged 70, 74. So really, we don't want to leave that cancer alone. I just recently treated a guy who was 90 years old. He's pretty healthy, 90. I didn't want him to die. He didn't want to die anytime soon, and he had a high-grade disease, and ordinarily I'm pretty cautious in men as they get into their upper 80s and 90s. But when you have this type of cancer, it can be a mean one. Even Gleason 7, you know, here you've got 40% mortality at 15 years with Gleason 7, even in men who are over age 70. So, you know, I often recommend treatment for these individuals. Now, things did change in the pre and post PSA era, and one of the things that changed along with it was the Gleason scoring itself. So this gets people confused. I've already shown you that Gleason had 1, 2, 3, 4, 5, and you put the two together for 2 plus 2 is equal to 4, or whatever. Well, it turns out that Gleason was studying hunks of tissue derived predominantly from specimens derived from transurethral resections, not little needle biopsies. So about the time that PSA came in, people started also doing little needle biopsies. They didn't have much tissue to look at. And they really couldn't tell what was a Gleason 1 or a 2 or a 3. And so inevitably, the pathologists got together and they just grouped it all together. So Gleason 3 plus 3 is equal to 6. That's as good as it gets. You cannot have, on a prostate needle biopsy, a Gleason score under a 6. And in fact, if you do, you better run and go get another pathologist because that guy doesn't know what he's talking about. That can occur. The other thing that happened is there was some additional refinement of the Gleason scoring system where the original Gleason scoring system became altered a tad. And in that alteration, some of the ones that were 3 kind of morphed into better 3s, and other ones kind of morphed into 4s. So things did change a little bit. The other thing that PSA added, and most people today are diagnosed with PSA-detected disease, is it gives you a lead time. The average time that PSA, and remember, averages are deceptive, but the average time that PSA will detect a cancer is about 10 years before it would be clinically apparent. So there's a lead time that gets built in when you have a PSA-detected cancer. So it's not just like you're coming in with a cancer with urinary obstruction. You can see that this modeling by Chris Parker, who's a very close colleague of mine over in London, a great guy, he did the modeling mathematically. This isn't real data, it's mathematically modeling. It's the same thing that Albertson did with the gray, meaning you die from something else, and that you've got this little tiny little sliver of plaque. But that's dying from prostate cancer. We can see the same thing here. And here the Gleason score is simplified. It's just less than 7, 7, and more than 7. So he just kept it real simple. But you can still see young men, even in the PSA era, with a Gleason more than 7, which means 8, 9, 10, that they really do pretty dreadfully. And even if you're PSA detected at age, 70 to 74, you still are probably going to have a real risk of death. Whereas if you're PSA detected in less than Gleason 7, which means 6, there's only one thing less than 7 we talk about, you can see the vast majority of men are not going to die from prostate cancer. So that's very important. To complicate things, brand new, not even in full print yet, this is what we call an EPUB, is the new Gleason score, led by Jonathan Epstein up at Hopkins. Some of you may have had your samples sent to Jonathan Epstein because I think he's probably the best pathologist on the planet when it comes to this stuff. He's led a large team that has tried to create a different system. First of all, he noted that the Gleason 9 and 10s are different than the 8s, because in the old system, they just put 8 to 10 together. 8, 9, 10 were all considered the same. Turns out the 9 to 10s are worse than those who have an 8. So the 8s stand alone, and then he also split up the 7s, because it depends on whether or not you're Gleason 4 predominant in your 7 or Gleason 3 predominant in your 7. So if you're 4 plus 3, you're on this curve. You're 3 plus 4, you're on that curve. And then here the 6s are, which is good as they get. So then put it on here. He wants to call everything category 1, 2, 3, 4, 5. And actually I like that because it splits the 7s, which is important. The 4 plus 3s goes in one bucket and the 3 plus 4s go in another. And it puts the 6s in category 1 so people don't come in and say, well, how come I don't have a 2, 3, 4, or 5, and how come 6 is as good as it gets? It makes it a little less complicated. Now, this is PSA relapse post-surgery. This is not survival, so please don't think these are dead people. These are living people with a PSA recurrence. So, but you can see how well these stratify out. I'm actually on what's called the American Joint Commission of Cancer that establishes the staging system that's used pretty much worldwide. A group of us are on that. And I'm going to recommend, and I think that most others will agree, that this particular system of analyzing the Gleason score is preferable and is the one that we're all going to sort of universally adopt. We like it. One of the other guys on the AJCC committee is an author on that paper. So, conclusion, Gleason score. Gleason score, determined by biopsy, is the most critical factor in determining prognosis for patients with localized disease. If you don't know what your Gleason score is, everybody knows their PSA. Half the people I talk to don't know their Gleason score. I don't really give a damn about the PSA. I want to know what the Gleason score is. That drives prognosis. I could, in fact, show you that pretty much every PSA between 0 and 10 is pretty much the same. I can show you more data that says every PSA between 10 and 20 is pretty much the same. And once it gets over 20, it starts getting a little worse. But people actually don't like to hear that because they want to calculate 14.2 and then it went to 14.8 and it went up, right? No, not really. If it goes from 14 to 18, maybe something changed, but not a lot. I had a guy in my office yesterday whose PSA went from 6 to 9. He's nervous as a cat on a hot tin roof. And I just said, slow down, slow down. I'm not as nervous as you are. You ought to take your signals of nervousness from me, not from you. So his PSA went up a tad, and he's as nervous as can be. I can understand that in some ways, but at the same time, there's more to the story than PSA. That's the critical part. Another thing is staging, okay? Your PSA doesn't tell you what your stage is. This is the simple way to do it. First of all, I kind of make it my business, unless you have metastatic disease, to do an exam. And what I'm feeling for is whether or not I can feel something in the prostate. If it's not palpable, then I call it a T1. If it's palpable but in the prostate, I call that a T2. If it's palpable and it's gotten out of the prostate, that's a T3. And if it's out here invading into the adjacent tissues like the rectum or the bladder, I call that a T4. So I assign a little stage to you. I say, well, you're a T1C. There's more to the staging system, or you're a T2A. I'm just keeping it simple. 1, you can't feel it. 2, you can. 3, it's outside. 4, it's gotten bad. And then you talk about the pelvic lymph nodes. They're either positive or negative, and that's typically a scan. And then other sites, positive or negative. These are somewhere outside the pelvic lymph nodes, and that would be metastatic disease. So we put people through these staging, and then we do what I call an initial risk stratification. The guy named Anthony D'Amico, who has an honor, and I'll tell you about that in a second, put together an initial risk stratification scheme. And there have been modifications to it we followed. Anthony D'Amico is the smartest man I ever met. Never met anybody smarter than him. He's an MD, PhD, works at Harvard, heads up the GU Radiation Oncology up there, PhD from MIT, full professor at Harvard when he's about 38 years old. Goodness gracious. Crazy guy. Good friend, answers his emails within 2 minutes. Never met anybody fast. He's the best emailer I know. Low-risk prostate cancer. T1 means you can't feel it, or T2A, and that's a little bump. Gleason 6, and PSA less than 10. You got to have all the above. You got to have a T1 or T2A, and a Gleason 6, and PSA less than 10. That puts you into low risk. We actually have a very low risk, but that depends on the biopsy results. We have a high risk, which is T3A, meaning it's getting out of the prostate. You got a Gleason 8 to 10 or a PSA greater than 20. These are not all the same, by the way. I would much rather treat a man with a PSA of 21 than I would a guy with a Gleason of 10. I can cure these pretty reliably, and these give me trouble. T3A just means it's outside the prostate. I bracketed this because if you can have this is the high, and if you're in between, it's a big grab bag. And there's a lot of people who say, well, intermediate is not very informative. I agree. So we further would stratify the Gleason 7s into 4+3s or 3+4s. We look at the number of positive cores. There's difference between somebody has 12 cores positive, 1 core positive, different, so there are things that we're throwing in the mix. But that's it. Low, intermediate, high. This is where we begin decision making. Local advanced. Seminal vesicles are into the rectum or bladder. That's not good. Or metastatic means it's out there and we can see it. So that's a problem. Treatment considerations. Low risk. Interesting, really interesting. In the PSA era, so since we've been using PSA, no treatment has ever been shown to be of any benefit in a low-risk prostate cancer, and surveillance is often the preferred option. Now, I just told you yesterday, I had a Gleason 6, the PSA was about 5, he had a T1C, and his brother died from prostate cancer. I get nervous about that, so actually I did recommend treatment for that guy with a Gleason 6, because I just didn't like that family history. And his brother died from prostate cancer at age 57, and he's 62, so it wasn't like his brother died when he was 98. So, you know, low risk, surveillance is what I tend toward. Intermediate risk, surgery or radiation plus hormones. I'm kind of keeping it simple. I'm not going, there are lots of different forms of radiation. We got seeds, we got non-seeds, we got external beam, we got IGRT, IMRT. There are more things than you can shake your stick at. The radiation plus hormones is standard here, or surgery. For high risk, it's surgery or radiation plus hormones, but the duration in the hormonal treatment is longer, 18 to 36 months. They tried in the high risk patients using 6 months. Turns out it wasn't long enough. People died faster, so that's why we go 18 to 36. A lot of people say, well, I don't want a year and a half or 3 years of hormones. I said, well, okay, well, we'll just show you the data. And after they see the data, they say, well, maybe I'll take the hormones instead of be dead. So surveillance is standard of care for low-risk cancer, treatment is standard of care for intermediate and high risk. Now, I do have this other thing, it's built in about life expectancy, right? Because remember, the 92-year-old and the 42-year-old are not the one and the same. The guys who are going to die within 10 years, no matter what we do, I don't necessarily have to get excited and treat their prostate cancer. They got bigger fish to fry. So, you know, I try to explain that to people. By the way, I've never met anybody who said, I'm going to be dead in 10 years. It doesn't matter if they're 98 years old, they're still saying, well, I feel fine. I don't know why we're going to be not treating me. I just demand to be treated. I said, okay, well, I just want to let you know what my recommendations are. High-risk cancer, surgery, radiation plus hormones, standard of care. This is kind of one, same sort of plot. We use a lot of these. We call them Kaplan-Meyers. Here, 100% of the people are alive. Here, 0% are alive. We've got two cohorts of men. Those people get radiotherapy alone, or those people get radiation plus hormones. These are for high-risk men. Cut off the top up there. You didn't see that. So these are people with T3, T4 disease, so pretty nasty disease. But you can see here the survival is, whatever that is, 65% at 8 years. Here the survival is maybe about 40% at 8 years. So by giving the hormones, you move the survival from 40% up to 65, for lack of a better term. We can go to the paper and get the exact numbers. But there's no question in my mind that hormones plus radiation is better than radiation alone. Not showing you, but there's additional data that shows that if you use hormones alone and then add radiation, that radiation plus hormones is better than hormones alone. You may say there's a control group missing. You are. But there are other studies which show that the combination is better than either one. So that's why we use radiation plus hormones in selected men who are being treated. So I've kind of covered localized disease right now, but there's more to the story, of course. And now we're going to talk about recurrent disease. I'm going to keep it after surgery, and we can talk about radiation. You know, everything is a nuance. That's why every patient is an individual. So recurrent disease after surgery. A lot of people don't get this, but radiation provides a second chance for cure. We can still cure you with radiation, even though surgery didn't work. And the problem that people have getting in their minds is it's their second, but it's also their last. And I have people, and I have smart people, and I look them in the eye and say, your odds of succeeding with radiation are not high. You have a really nasty cancer. You probably only have about a 20% chance of this radiation working. And they say, well, what you're saying is that it's probably going to fail. And I said, unfortunately, I think in your case, you're probably going to fail. But I recommend it anyway. They look at me and they say, well, why do you want to recommend a therapy that's probably going to fail? Because the alternative is 100% failure. If you don't get any treatment early on, and I'll show you how important early on is, then you don't have any chance for cure. I'd rather have a 20% chance of cure than a 0. PSA doubling time is critical for prognosis, absolutely beautifully displayed in a series of studies from Hopkins. Hormonal treatment is debatable. This is efficacy, and these are PSA recurrences. So we had the same sort of thing. This would be 100%. Right here, this is 0%. Nice big group of individuals, 1,540 patients. And all they did is they stratified by PSA at the time of radiation. Was a PSA less than 0.5? Here's greater than 1.5. Oops, say pointing here. It's really pointing to this line right here. This is 0.5 to 1. This is 1 to 1.5. And you can see that by the time you get a PSA up to 1.5, the odds of having, these are months over here, so I guess that's 10 years right here, so this will be somewhere around a 10-year mark or so. If you wait to get radiated until the PSA is 1.5 or higher, it ain't going to work. I mean, it's just not going to work. So here you can see even with less than 0.5, it's only about 40%. This is a great study, and it shows the stratification of risk according to the baseline PSA at the time of radiation therapy. But if you go down lower, these curves get better. It wasn't done here, but the bottom line is that I'm now starting with the supersensitive PSA assays. I'm really taking this down to about 0.08 or 0.1. So I'm cutting way down. I don't let anybody go to 0.5 in my practice. By the way, if you don't have a prostate, you shouldn't have a PSA. It ought to be 0. There are a few exceptions to that, but the real truth is no prostate, no PSA. It ought to be 0. Now, we can't measure 0, so we call 0 less than 0.01 on my assay. If you go to Quest or a lot of the other outside labs, they can't measure as well as we can measure. They only go down to 0.1. So if I'm worried about low PSA, I pretty much insist you come to Tulane instead of getting your outside lab. So I've got people to drive in to get their PSAs. But it adds value. If I'm detecting a recurrence, I want to find it early. I'm not waiting to any 0.2 or anything like that to get moving. PSA doubling time. These are people, and it's very interesting. You know, Hopkins is a great place. They have great prostate cancer programs and people. It also turns out that they did not believe in radiation after surgery. They believed that if you have surgery, you cannot benefit from radiation because your prostate's gone. So they had a policy of simply observing people. Now, it turned out that the data was moving contrary to their preconceptions. And like a lot of bright, smart people, they got it in their head that they were so smart they could ignore the data. Even Hopkins has come around. It took them a while, but they did come around. But they observed these people, didn't do anything, just watched them until they had metastatic disease and then treated them with hormones. And what they found out, if your PSA doubling time is less than 3 months and you're rising up after surgery, well then the median, that's where you are at 50% right here, 50% of the people are dead at about 6 years, okay? Now this is older data, it doesn't reflect what would happen today, but nevertheless, it does a stratification by doubling time. Here you can see if the PSA doubling time is greater than 15 months, you practically don't have to worry about it. At least at 10 years, you had a couple of deaths in this cohort, and some people falling off out here. But nevertheless, I spend a lot of time calculating approximate doubling times for people in a prognostic category of recurrence with PSA after radical prostatectomy and radiation. I put them in these different risk buckets. This guy I've got to worry about. This guy I might just watch. I've got a guy who's about 85 right now, and he's got a PSA doubling time of 15. His PSA is up to 2. He's worried as could be. And I said, look, I'll see you back in a year. If you die in the next year from prostate cancer, then you'll be the first one I've ever seen. So just come on back in a year and we'll check your PSA. He's all nervous about it. I'm not, okay? I have this data to tell me he's going to be fine. On the other hand, I'm sitting up here watching the PSAs jump and jump, and I'm nervous. I'm starting to try to do things. Now, some people end up on intermittent hormonal therapy. Some people want continuous hormonal therapy. And there are different ways of doing intermittent, there are different ways of doing continuous ADT, that's androgen deprivation therapy. There's a nice study in the New England Journal in 2012 to look at intermittent versus continuous. These are people with non-metastatic disease. You had to have that. Everybody had to have radiation. Everybody had to have non-metastatic disease in order to get into the study. And they looked, the median survival was 9 years. By the way, most people did not die from prostate cancer in this study. So what you see here is that intermittent or continuous, it doesn't add any advantage to go continuously. And in fact, as the people on intermittent, they had better QOL, that means quality of life. They had better physical functioning, better fatigue. These numbers, by the way, if you're not a statistician, those are statistical ways that we display the truth. Here, what that means is less than 1 chance in 100, p less than 0.01. Less than 1 chance in 100. So physical functioning, fatigue, hot flashes, desire for sexual activity, erectile function, everybody on intermittent is doing better than continuous. So one of the things I often do is just take people off the hormones and just watch them and then treat them intermittently if needed. But there was a guy who wrote an editorial about this New England Journal article, and I entitled it Androgen Deprivation, Continuous, Intermittent, or None at All. Because the truth is, we're missing an essential control arm. It's not just intermittent versus continuous. It's like, how would they do if we didn't treat them until they had metastatic disease? And the answer is we don't know. And there's some reason to believe that maybe waiting is not so bad. Everybody gets nervous when the PSA is going up. Some people get more nervous than I do. But if you're going up fast, I'm probably more of an interventionist. If you're going up slow, I'm probably going to be slow. I got people in the audience who I won't name who've kind of been slow for a while and now they're speeding up. And we might have to think about what happens when they speed up. But nevertheless, I do make a stratification based on PSA doubling time. Age and comorbidities, of course, are also important. So, localized disease, recurrence. Let's talk about something that we don't have to deal with that often. It's only about 5% of men in the United States today will come in with metastatic disease when they're diagnosed. I just mentioned I saw the young man from Alabama. He's got a PSA at 300. He's got stuff in his bones, stuff in his lymph nodes. You know, it's not a pretty scene out there for some people. So this is a beautiful presentation. June Asco, Ringside Clinical Oncology, oral presentation there. It's a little bit complicated, but docetaxel, which is chemotherapy for hormone-naive prostate cancer in men with metastatic disease. And there were a lot of patients. This is a crowning achievement of the English prostate cancer group. They enrolled 2,962 patients on this particular protocol. They randomized people to standard of care, zoledronic acid, which is bisphosphonate, or chemotherapy, or both. And they had 593, 592, 593, 1184 patients. A lot of patients, a lot of randomization. Very interesting. Within the UK, people are more willing to be randomized than they are in the US. If I told somebody I was going to randomize them to one of 4 arms, they'd look at me and say, you're crazy. In the UK, they seem to go along with it. It's quite interesting. Here's the bottom line. These are M1, meaning metastatic, and they're positive metastatic disease. Docetaxel was the chemo. Everybody got standard of care, which was the androgen deprivation therapy. And here are the survivals. We talk about medians because that's what happens for 50% of the people. Median in the normal group, just androgen deprivation, was about 43 months. If you got the chemo up front, the median was 65 months over here. 22 months is pretty good. And I realize that everybody wants more. I want more too. But 22 months prolongation survival. We expected to live 43, when we call that 44 for math purposes. You're going out by 22. That's extending your life by 50%. I mean, that adds value. What I hope, and one of the reasons that I do endorse this therapy, now not only the standard of care for the men who are chemo fit, not everybody's chemo fit, is that when people are living longer, gives me more tricks in my bag that I might be able to use. The good news for everybody in this room and every patient in the world is that doctors are getting smarter. Our IQ is not going up, but we're getting more data. And I want to be able to give you the benefit of getting a longer survival now so I can have more tools in my tool chest when I'm attacking this thing 3, 4, 5, 6 years down the line. I am going to be better down the line than I am today because there are a whole bunch of smart people working on this disease. So that takes metastatic, and then now we got to come over here. I'm going to ignore this part because it's hard to talk about. We don't have standard of care. So if you do have metastatic disease and you're progressing despite hormonal therapy, we actually have a whole bunch of trials, 1, 2, 3, 4, 5, 6, 7, 8 trials that have demonstrated a prolongation in survival. Here's hazard ratio. Let me explain that. So if your hazard ratio is 0.79, that's compared to the control group. What that means is a 21% reduction in the risk of death. And you can see most of these will reduce death. Here you've got a pretty good one right here. This is about 37%. That's enzalutamide versus placebo. Here's 0.7 right here. This is a 30% reduction. But you can also see that these survivals vary dramatically. You can see in this trial that the median survival was 32.4 in the enzalutamide group, and here's 30.2. Well, the first thing is you say, well, by damn, that's not very impressive. And then you look over here and you see 1916, and these patients are not all the same. They're different patients going into these different buckets. One of the things very important, and I want patients to understand, because they see this and they get discouraged. They say, goodness gracious, I'm going to take these medications and I'm going to live 2 extra months. That's just really not working. Mm-hmm. Well, the thing is that a lot of these patients who were treated with placebo initially then went on to receive a whole gamut of other therapies, some of whom actually received enzalutamide again. So look at these comparisons. It's not A versus B. The truth is it's A, B, C, D, E, F versus B, A, C, D, E, F. So everybody's getting a lot of therapies, and we've actually reached a point. I'm actually going up to the FDA in less than 2 weeks, September the 14th or something, to have a discussion about this problem. Everything has been approved on the basis of survival, but now there's so many therapies, it's not even clear that any one therapy is going to help somebody live longer. We may have to come up with different endpoints other than survival. So we're going to have a serious talk with the FDA, trying to figure out how can we change the goalpost about what meets drug approval. So everybody's discouraged by this, but don't be quite so discouraged. We have some active agents. We have a bunch of them. We have docetaxel, Cipacel-T, abiraterone, enzalutamide, cabazitaxel. These are post-docetaxel studies in radium, all of which prolong survival. 6 different agents prolong survival, and we try to work as best we can. And now what we're doing, these are all single-agent trials. I mean, prednisone hardly counts. Enzalutamide are nothing. Well, now we're putting stuff together. We're saying, hey, I want you on abiraterone and I want you on radium. And I'm looking around the room, there's some people on combinations of things, and that's new. We didn't used to do that. So those are clinical trials we're putting together now. And we're putting together a variety of these things in combination, because I figured that, hell, 1 + 1 may not equal 2, but maybe it'll at least equal 1.5. It'll be better than 1. So our job is to continually improve upon what we have been given to work with. And a lot of that, I'm not talking a lot about clinical trials today, but I should. And the reason is, some people are scared to say, I don't want to be on a clinical trial. I don't want to be in experimental therapy. Well, some of our clinical trials are actually just combinations of therapies that would not otherwise be available. Now, I've also learned how to cheat a little bit, because it turns out that the intravenous part of Medicare and the oral part of Medicare don't talk to each other. So if I use a combination with 2 orals, they won't approve it. But sometimes I can get an oral and IV put together and get it approved. So, there's all sorts of games that we play. But nevertheless, clinical trials are how we make progress. And when we put you on a clinical trial, I assure you, you get the very best of care, and we pull in the team. And usually I explain the rationale. I want to do a clinical trial because of this. This is why a clinical trial may be good for you. Or maybe it's not. I tell people that too. So when I'm making treatment decisions in the clinic, everybody says, okay, well, what do you use first? And I have a little bit different scenario. That's like somebody coming up to me and saying, I have a PSA of 9, what do I do? Okay, how much does the drug cost? Okay, I got some pretty expensive drugs out here. I can prescribe drugs that cost, like the Provenge, $125,000.
Okay, you put your $125,000 check on the table, then we'll talk about it. Most people say, I'm not going to do that. I want my insurance to pay for that. I pay insurance. I'm not putting $125,000 out. And then, we get to hear, oh, so cost is a major issue to you. You don't have a bottomless pit for a wallet. Okay, well then we may have to work within the ramifications and allowabilities of your insurance. So we have people like Linda sitting over there who's going to work with those insurance companies, do the pre-certifications, find out what the insurance is going to pay. I had a guy today, I prescribed abiraterone for, thought they'd be a good drug for him. And it turned out that the thing cost $6,000 a month. So what I told him is, I said, I'm going to prescribe the drug, but before you agree to accept receiving the drug, we're going to find out what it costs you out of pocket. Because actually, people don't give a damn about what their insurance pays. They only give a damn about what's in their wallet. So it turns out that the insurance was going to pay $5,925 a month. He's got a $75 copay. That's pretty good. I said, take it. $75 a month, go ahead and do it. But cost is a real issue for the drugs that we work with. And we're very careful not to deplete your wallet. By the way, one of the most common causes of bankruptcy in the United States today is being diagnosed with cancer and then having to deal with the financial repercussions. And it's dreadful. We order MRIs, CAT scans, bone scans, all these expensive drugs at a drop of a hat. And if you don't pay attention to the cost, it can bankrupt virtually anybody. I don't care how thick your wallet is. So cost is a big issue. Availability of clinical trials. I might have a great clinical trial just for you, and I may want to tell you about that, or I may not. So if I have a clinical trial available or not, that can influence the way I approach you. Performance status, that means how well are you doing. So unfortunately, I had a very unpleasant test today of making a decision over a guy in the intensive care unit. He has what we call small cell lung cancer. I do essentially 95% prostate in my clinic with a little bladder, renal, and testicular thrown in. But in the hospital where I cover for a couple of months out of the year, I go and I see all the cancer patients regardless of what they have. And that's part of my teaching obligation to Tulane. They pay me to teach, and I go around with all the patients and teach the residents and stuff. Well, I got a guy sitting in the ICU. He's in bed. He's lost, I think, 55, 60 pounds, weighed 125 pounds, looks like a little skeleton warmed over, and he has small cell lung cancer. He's not that old, he's only 71. I took one look and I said, this isn't going to work. Chemotherapy is not going to work for this guy. I'm going to hurt him. I put his ECOG performance status, ECOG Eastern Cooperative Oncology performance status about 4. I get chemotherapy to people with an ECOG 4. They're dead. I kill them. So I'm not treating this guy because he's not fit enough to be treated. Age, other medical issues, already mentioned age, comorbidities, 99-year-olds, 49-year-olds, not the same. You have to make adjustments. Other medical issues, a guy with a horrible congestive heart failure, that's different than somebody who has a good, healthy heart. Laboratory assessments, a lot of people know this. So I come in and I said, I need to look at your labs before I finalize what I'm going to do decision-wise. And I need to look at your white count, your platelets, your liver function, hemoglobin. I got to look at all that stuff because times we can have, liver functions out of sight, and I can't give you that drug, or maybe your platelets are too low and I can't give you this drug. So I have to draw those labs in order to inform me about the safety of the treatments we're going to do, symptomatic or not. Do you have symptoms or not? If so, what are the symptoms? How much are the symptoms? So, there are people who have focal symptoms. I typically ask a simple question. If you put your hand in the spot where you're hurt and we take that pain away, will it make a difference? And if the answer is yes, I can consider them for external beam radiation. We can radiate there. We can usually, about 80% of the time, relieve the pain there. Of course, radiation doesn't work where you don't shoot, but nevertheless, it's a great tool to have in your tool chest. Doesn't prolong survival, but it sure does make a difference in terms of treating people. Response and resistance to prior therapies. If you've been on prior therapies, how did you respond, or were you resistant to it? Saw a young man yesterday, don't like this, short duration of hormonal response. And I said, okay, well, try second generation hormone, and it looks like he's already failing. These guys are resistant. This guy was resistant to his prior therapies. They give you 2 prior therapies. Looks like he'll be resistant to both. I got to move him on to chemo. I can't use any more hormones on this guy. But on the other hand, there's some people who go through chemo and they do well with it, and they're going to say, oh, okay, so you can tolerate chemo pretty well. Well, I got another chemo that might be of value, so I can bring that in. So response resistance to prior therapy counts. Tolerance and intolerance. Now, other people, they get chemo and they feel like hell. They say, I'm not taking more chemo. I said, okay, that's fine. We don't have to give them more chemo. But it does limit our options, of course. Burden of disease. Do you have 1 bone met? Do you have 101 bone mets? I see plenty of people with 101 bone mets. Okay, if you got 1 or 101, you're not the same person. I have to figure that out. Where are they located? Liver. I don't like liver. Liver gives me the fits. Liver is a more aggressive disease. So I got liver mets. I got to think about more aggressive therapies. I have to think about monitoring the scans. PSA, which is marvelous if you don't have a prostate, becomes poor when you've got a liver met because it doesn't make a lot of PSA. So I got to figure out where the PSA is coming from, and a liver met patient's probably coming from someplace outside the liver. So I have a different strategy for people here. You know, maybe the radioactive beats into the liver. We'll shock them with that. Pace of the disease, is moving fast or slow. So, yesterday, saw a guy whose PSA is going up slow. He's all in a tizzy because it's going up. I'm not in a tizzy because it's slow. People are rising fast, kind of pump me into action a little faster. So we have to pay attention to that. Systemic or focal progression. Now, some people, they progress in one spot and everything else is fine. In which case, maybe what I want to do is just radiate that one spot and leave everything else alone. So if you're progressing in 59 spots, I got to have a systemic therapy. You're progressing in one spot, I might just use one. Phenotype, a little bit complicated. Sometimes we ended up with neuroendocrine. Hated to do this. I sent a 50-year-old to hospice this week. 50. He went neuroendocrine on us, and neuroendocrine is a very poorly differentiated, extremely aggressive phenotype. No longer responds to androgens. Doesn't make any PSA. His PSA was stable at 10. PSA did not tell the story. God-awful disease growing in his pelvis. It grew out of control. He'd already been through chemo on 2 occasions. He said, I don't want to do it anymore. He's not going to respond to hormones. I sent him to hospice. Okay, 50 years old. Neuroendocrine disease, that's bad. Typical adenocarcinoma is what you should have. And then, of course, patient preferences. People come in. So long as patient preferences are sort of reasonable and logical, I'm pretty much up to that. I don't let people get out of bounds on their preferences, because if they want to do something stupid, they'll have to get another doctor. On the other hand, there's room for patient preferences. And he said, well, I'd rather do this than that. I said, well, that's fine. That's reasonable. We can do that. This is not dyed in stone, carved in stone. We do have a whole lot of flexibility at times of what our choices are. This is what I'm thinking about. People walk in the clinic, I think I got a little simple algorithm. I wish it were that simple. There's a lot that goes into my decision making. I do it so fast because I've been doing it for 25 years. You don't see me doing it, but I'm doing my little mental calculations as I'm running down. See here. I want to leave plenty of time for questions, and I hope we have plenty of time for questions.